welcome. Thank you all for joining us today. Before we begin, I'd like to take a moment to introduce the Children's Cardiomyopathy Foundation, also known as CCF. CCF is a national nonprofit organization dedicated to pediatric cardiomyopathy, a rare, chronic, and potentially life-threatening disease of the heart muscle that can affect children of all ages. Founded in 2002, CCF works to improve the lives of children diagnosed with cardiomyopathy while accelerating research toward better treatments and ultimately a cure. CCF's mission is to advance research, education, awareness, and advocacy for pediatric cardiomyopathy, while also providing meaningful support to children and families living with the disease. To support this mission, CCF offers a wide range of programs and services for both families and healthcare professionals. These include funding and promoting research to better understand the causes and treatments of pediatric cardiomyopathy, as well as educational initiatives that share the latest information with parents, caregivers, and medical providers. For families, CCF provides a variety of support resources through educational materials, webinars, an online community where families can connect and share experiences, and its ambassador program, which connects parents for one-on-one support. CCF helps navigate the challenges of life with For families, CCF provides a variety of support resources through educational materials, webinars, an online community where families can connect and share experiences, and its ambassador program, which connects parents for one-on-one support. CCF helps families navigate the challenges of living with a rare heart condition. CCF also offers families access to its Centers of Care program, which recognizes hospitals and academic medical centers that provide high-quality, specialized care and comprehensive disease management for children with cardiomyopathy. At its core, CCF strives to ensure that no family facing pediatric cardiomyopathy feels alone, and that every child affected by this disease has the opportunity to live a longer, healthier life. We're grateful for the opportunity to join transplant families in announcing today's speaker on pediatric heart transplant. Dr. Ashwin K. Lal is a professor of pediatric cardiology at the University of Utah and a pediatric cardiologist at Intermountain Primary Children's Hospital in Salt Lake City, Utah. He is a graduate of Boston University School of Medicine, completed his pediatric residency at Lurie Children's Hospital, Northwestern University, and his fellowship at Stanford University. His clinical interests include cardiomyopathy, heart failure, and heart transplantation, with an interest in multi-center collaborative research. Dr. Lal is an active member of the Pediatric Cardiomyopathy Registry, Pediatric Heart Transplant Society, and Pediatric Heart Transplant Network. Dr. Ashwin K. Lal is a professor of pediatric cardiology at the University of Utah and a pediatric cardiologist at Intermountain Primary Children's Hospital in Salt Lake City, Utah. He is a graduate of Boston University School of Medicine, completed his pediatric residency at Lurie Children's Hospital, Northwestern University, and his fellowship at Stanford University. His clinical interests include cardiomyopathy, heart failure, and heart transplantation, with an interest in multi-center collaborative research. Dr. Lal is an active member of the Pediatric Cardiomyopathy Registry, Pediatric Heart Transplant Society, and Pediatric Heart Network, and serves on the National Medical Advisory Council for the Make-A-Wish Foundation, as a medical advisor for the Children's Cardiomyopathy Foundation, and is the chair of the research committee of the Pediatric Heart Transplant Society. Thank you.
I want to thank transplant families for giving me this opportunity to talk about the road to transplant, specifically for families with cardiomyopathy. My name is Ashwin Lal, and I'm a pediatric heart failure and heart transplant doc at the University of Utah and Primary Children's Hospital. First and foremost, I just want to let you guys know that as families, you are not alone. If your child has been diagnosed with cardiomyopathy, you may be feeling overwhelmed, scared, or unsure of what comes next. This talk is designed to walk you through this journey, from diagnosis to what the road to transplant looks like. I want to remind you that 1 in 100,000 children are diagnosed with cardiomyopathy each year. Cardiomyopathy is the most common reason for pediatric heart transplant, although this is evolving. and you have a team of doctors, nurses, and social workers that are really all part of your child's team. You also have great organizations like Transplant Families and the Children's Cardiomyopathy Foundation that can be an additional resource. So what is cardiomyopathy? As we all know, the heart is a muscle. Cardiomyopathy means the heart muscle is sick. It may become too weak, too thick, or too stiff to pump the blood the way it should. This is different from a congenital heart defect or a defect that a child is born with. In cardiomyopathy, the structure of the heart is normal, but the muscle doesn't work properly. What causes cardiomyopathy? It can be from various different causes. They can include genetic or inherited causes. Sometimes it can run in families. A gene change can cause the heart muscle to grow or function abnormally. After a viral illness, a virus can sometimes inflame the heart muscle, and this is usually called myocarditis. Some children may have metabolic conditions, which are rare conditions that affect how the body processes energy. But the majority of children have an unknown cause to their cardiomyopathy, and often we call this idiopathic. We don't find a specific cause, but it doesn't limit the way that we treat children, and we treat them similarly regardless of what the cause is. Traditionally, we think about 4 different types of cardiomyopathy. The first is called dilated cardiomyopathy. This is most common in children. The heart stretches out and becomes weak. It can't pump blood as well. Oftentimes we say it has poor squeeze. In hypertrophic cardiomyopathy, this often runs in families. The heart muscle gets too thick, making it harder to fill with blood. Restrictive cardiomyopathy is the least common form of cardiomyopathy, but many of us feel like it is the most serious. The heart becomes stiff and can't relax properly to fill with blood. It has poor relaxation. And finally, left ventricular non-compaction cardiomyopathy is a type of cardiomyopathy where the heart muscle has a spongy texture that affects its pumping. This can have features of any of the prior cardiomyopathies. What are signs and symptoms of heart failure when a child has cardiomyopathy? Well, they differ depending on age. In infants and toddlers, this may be shown by fast breathing, poor feeding, or sweating during feeds, which is often one of the most significant exercise that they do. Children may not be gaining weight. They may have pale or gray skin color and are unusually sleepy or hard to wake up. In older children, this can present with chest pain, heart racing or palpitations, getting tired easily during activity or sports, feeling dizzy or fainting, or being short of breath with really everyday activities. Children can sometimes have swelling in their legs, ankles, or belly. You'll want to seek immediate help or go to the emergency room if your child has sudden trouble breathing, severe chest pain, fainting or loss of consciousness, skin that looks blue or very gray, or they become unresponsive. It's really important that you trust your instincts because you know your child best. The types of cardiomyopathy can really lead to different roads. In dilated cardiomyopathy, there are often more medications to trial to see if we can help children feel better and oftentimes even improve the squeeze of their heart. When they do progress to transplant, it's often due to progressive heart failure symptoms or poor output to other organs such as their liver and kidneys. There are more options to stabilize these patients. In hypertrophic cardiomyopathy, these patients are less often moved to transplant during their childhood. But if they do move to transplant, it's usually due to either uncontrolled arrhythmia or progressive heart failure symptoms. Restrictive cardiomyopathy is less frequent, but these children more often move to transplant. The reasons for transplant may be due to arrhythmias, progressive heart failure symptoms, or increased pressure in the lungs. There are fewer medications or options to stabilize these patients, so oftentimes we need to be more preventative and list these patients earlier. And finally, in LV non-compaction, these patients often follow the path of the cardiomyopathy that they mimic, as it can manifest with features of dilated, hypertrophic, or restrictive cardiomyopathy. Your child's cardiologist will explain what it means for their specific care plan. When does transplant become the path? A heart transplant is considered when the heart muscle has become too weak or too stiff to respond to medications and devices. It's not a failure, it's the next step toward giving your child a healthier life. Oftentimes, their heart function continues to decline despite maximal medical therapy, and they may have severe symptoms that now limit their daily life, where they can't eat, play, or grow well. They may have life-threatening arrhythmias that can't be controlled and may need additional support, such as mechanical support via ventricular assist device or ECMO. The decision to list for transplant is never taken lightly. Your medical team will have many conversations with you before this step, and you'll always be part of this decision and discussion. We oftentimes start with outpatient medications, but when outpatient medications aren't enough, we can advance to devices or procedures or hospital-based treatments. These can include IV hospital-based medications or inotropes. They're medications that are delivered intravenously to help with the squeeze or relaxation of the heart muscle. They can include ventricular assist device, a mechanical pump that helps the heart move blood through the body. It's used when the heart is too weak on its own, and it can be a bridge to transplant, keeping your child strong while waiting for a new heart. Finally, ECMO, or extracorporeal membrane oxygenation, is a machine that temporarily does the work of the heart and lungs and can be used in emergencies when the heart needs complete rest. What should you expect from the transplant evaluation? Well, before listing, your child will go through an extensive evaluation. This usually takes several days and several steps. Oftentimes at my center, I call this transplant boot camp, and it includes heart tests such as a detailed echo, a repeat cardiac catheterization, and oftentimes cross-sectional imaging, which may be an MRI or a CT scan, along with extensive blood work. This blood work looks at the blood type of your child, antibody levels, and infection screening, as well as organ function tests. These organ function tests assess how the kidneys, liver, or lungs are doing and whether they're healthy enough to undergo a transplant, a heart transplant, or if they may even need to be transplanted as well. You'll have many meetings with a social worker, a psychologist, a nutritionist, a pharmacist, and many members of the transplant team who will all in time become a part of your family. You'll have meetings with a financial counselor and discussions about insurance, housing, and transportation to try to ensure that we can support your child, your family, and this new organ that will become a part of your life. After the evaluation, a multidisciplinary team meets to review all the results and decide if transplant is the right next step. If so, your child is placed on the National Transplant Waiting List. So what makes a good donor for your child? Well, it certainly starts with good function of the heart, but there are other variables that make a good donor. They include distance to the recipient center. What we know is that when a donor becomes available, the longer that the heart sits on ice, the harder it is to restart or reanimate. So we usually are not willing to go more than 1,500 miles unless there are unusual circumstances. Size is also important. The heart needs to be large enough to pump blood to all the organs, but still fit inside the child's chest cavity. As an example, I often say we're not going to take a heart from somebody who is an NBA player size and put it into a 2-year-old because it wouldn't fit in their chest. But at the same time, we're not going to take a heart from a neonate who's only 1 month old and put it into a 5-year-old because it wouldn't be large enough to do the job that is necessary for a 5-year-old. And finally, we look at blood type and antibodies. We need to choose a good immunologic match so that the immune system does not attack this new foreign heart. What influences wait times related to transplant listing? Well, there are a number of factors. The first is medical urgency. Here in the United States, we have a system that includes status 1A, 1B, 2, and 7. This is defined nationally based on the diagnosis of a patient and their illness severity. It should be noted that children with cardiomyopathy are often at a lower status than children with congenital heart disease when on the same amount of medical support based on the risks related to getting to transplant. Age and size are also important. The number of donors and recipients are different based on size, and this is simply a matter of supply and demand. For better or worse, we have more donors for teenagers, as there are more risk-taking behaviors in adolescents and young adults. Blood type is also important. Traditionally, we've done compatible blood type transplants, but over time, we've noted that children under the age of 1 can really take most blood types, and children under the age of 2 have also been successful. We now have emerging data that it may be safe to do incompatible heart transplants in children over the age of 2, but this varies based on center. Antibodies are also important, and your child may have antibodies due to previous exposures, including graft material, surgeries, or transfusions that identify some donors that may be a better match. And then the time waiting or accrued time at a specific status can influence their wait times. While medical urgency is nationally regulated, these other variables can vary based on a center's comfort, experience, and really their attempts to balance the many risk factors they may be facing. The wait for a heart transplant can really be weeks, months, or even years. What happens during that wait? Well, your child may wait in the hospital or at home, depending on how stable they are. They'll have regular checkups and blood tests to monitor heart function along with other organs. If they are on a dischargeable ventricular assist device, your family will learn how to care for the device at home. You must be reachable 24/7 when a heart becomes available, as things can move fast. And you'll want to keep a packed hospital bag ready at all times. On the emotional side, it's okay to feel scared, frustrated, or sad. These feelings are normal and valid. Ask about support groups, whether they're local families or connecting with other transplant families across the country. Keep a journal, write down questions, feelings, and milestones, and let your child's school know, as many hospitals have teachers and tutors. Try to celebrate the small wins. Have a plan for siblings, pets, and your home. The day has come that you've been waiting for, and you get the call about your child having a donor available. You'll be told about the heart being available, and you'll want to get to the hospital as quick as you can, but in a safe manner. Preoperatively, your child is prepped for surgery. They have blood tests, IV lines, and consent that's obtained. The surgery itself typically takes 4 to 8 hours. The old heart is removed and replaced. Your child will go to the ICU where they'll recover with a breathing tube, chest tubes, and many IV medications. Hopefully, after a few days, your child will be able to go to a step-down floor where they'll continue their gradual recovery over 1 to 4 weeks, learning their new medications and routines. This can be shorter or longer depending on any complications that might happen and depending on how sick they were going into the transplant. Finally, your child will go home where they may be discharged locally with a detailed plan for medications and follow-up. At my center, we cover multiple states, and so oftentimes children need to stay in our local area for 4 to 6 months before they can return to their states that may be many hours away. One thing to note is that during the surgery, a member of the team will give you updates, but on the day of the surgery, I have a few pearls that I like to give families. You'll want to have a support person with you, but you'll want to keep your inner circle small. While inherently any family is going to celebrate that their child is getting a transplant, it's still a big operation. And if there are any complications, you want your inner circle to be small so that you don't have to communicate to multiple family members about any complications that are taking place. You'll want to try to keep as small of a social media footprint as possible. In this day and age, connections can be made, and you want to really focus on your child and not necessarily have too much communication that may even come from a donor family if connections are made. And finally, you'll want to suppress any curiosity you have about the donor. It's natural to be curious, but you really want to respect that somebody made a courageous decision to donate. And the story on the other side is never one that you want to know on the day of your transplant. What does life look like after transplant? Well, your child will oftentimes be on more medications after transplant than they were on before transplant. Some of these will include anti-rejection medications or immunosuppressants. Your child's immune system will see this new heart is foreign and will try to fight it. These anti-rejection medications teach the immune system to accept the new heart. Your child will take these every day at the same times for the rest of their life, and missing doses can increase their risk of rejection. Some of these common medications include tacrolimus, mycophenolate, everolimus, sirolimus, or prednisone. Some of the possible side effects include a higher infection risk since we are suppressing the immune system, effects on the kidneys, which will be regularly tested and monitored. Children can have weight gain, mood changes, or tremor, and you'll want to talk to your team about any concerns. And children can be at risk for cancer, as they are at a greater risk for all types of cancer, including a special type of cancer called PTLD, which is a lymphoma in post-transplant patients. Some medication tips or pearls include setting alarms on your phone for medication times, using a pill organizer to stay on track, and never skipping or doubling up. Life after transplant includes a lot of follow-up care. You'll have frequent clinic visits that may start twice weekly and then space to weekly, monthly, and then every few months as your child stabilizes. They'll oftentimes have blood draws with each of these visits. Children will have heart biopsies, which are small tissue samples from the heart via cardiac catheterization to check for rejection. These are more frequent in the first year and then decrease over time. They'll have frequent echocardiograms to check on how the new heart is working. They'll want to have infection precautions, including hand washing, avoiding sick contacts, and your child may need to wear a mask in crowded places during flu season or viral season. You'll want to keep all your vaccinations up to date, and your team will guide you on which ones are safe. They'll need ongoing dental care, emotional check-ins, as it's normal for your child and for you to have big feelings after transplant. Social workers and psychologists are oftentimes part of your team, and you should definitely use them. Most children return to school and many activities, and your transplant team will help you know when it's safe. What are some warning signs when you should call the transplant team? After transplant, you really become an integral part of the care team, and you'll want to know some of these signs. They include signs of rejection, which may include fever, feeling more tired, shortness of breath, swelling, poor appetite, less activity, or weight gain. Many of these are the features that you were looking at when your child had cardiomyopathy and potentially heart failure. Signs of infection may include fever, cough, runny nose, sore throat, rash or skin changes, diarrhea or vomiting, pain or redness at wound sites, or burning with urination. The golden rule is that when in doubt, you should call your transplant team. You're never going to be judged for calling too much, and your transplant team would rather hear about you about a false alarm than miss something important. What does daily life look like? Well, you'll want to take medications at the same time every day using alarms and pill boxes, and never running out of those medications and remembering to refill your prescriptions early. You'll want to have techniques for staying safe and avoiding infection, including hand hygiene. You'll want to emphasize the importance of nutrition, as a healthy diet supports recovery, and some foods you may be encouraged to avoid. You want your child to be active. That's part of the reason that they had a heart transplant. And children can be active, and your team will guide you on what will be safe. You'll want to start slow and then build up your activity. You also want kids to go back to school, as most do return to school, and many may need some assistance as they're returning back to school. And then finally, you'll want to take other precautions, such as sun safety, as children are at increased risk of skin cancer. Self-care is also very important. Your child needs you healthy, rested, and supported. Taking care of yourself is not selfish, it's really essential. You'll want to accept help, letting family and friends help with meals, siblings, errands, and really just saying yes. You'll want to talk about it with others, sharing your feelings with a counselor, support group, or a trusted friend. You'll want to rest whenever you can. Sleep deprivation is real. Nap when your child naps, and ask someone to take a shift. You'll want to take breaks, because even 15 minutes outside, a walk, or a cup of coffee alone can recharge you. One of the best analogies that I love is that when the flight attendant says, put your own oxygen mask on first, that applies to this journey too. Don't forget about siblings and family. Siblings can feel it too. They may feel scared, jealous of the attention, guilty, or confused. These are all normal reactions. You'll want to talk honestly at an age-appropriate level using simple language. Your brother's heart is sick and the doctors are helping him get a new one. You want to maintain routines as much as possible for siblings, including school, activities, and play dates that help them feel stable. You'll want to include their siblings by letting them visit the hospital, meet the nurses, draw pictures for their siblings' room. You want to watch for behavior changes such as acting out, withdrawal, or sleep problems, which are all signs of regression that can be signs a sibling is struggling. You can ask your social worker for help. Grandparents and extended family may also need support and information, considering having them attend a clinic visit or family meeting. And oftentimes, family counseling is available through many transplant programs, so try to take advantage of it. This is a family journey, not just a patient journey. There is hope as the long-term outlook for transplant can be wonderful. There's a 92% one-year survival and an 87% three-year survival, and this is improving every year. The median graft survival is 16 to 20 years, depending on the age of the child. Children who receive heart transplants can go back to school and keep up with their friends, play sports and be active, grow up to attend college, have careers, start families on their own, and really reach many of the dreams that you may have for your children or they may have for themselves. They can live full and joyful lives. As transplant is not an ending, it's a new beginning. You'll want to take advantage of resources that might be available, including Transplant Families, the Children's Cardiomyopathy Foundation, the United Network Organ Sharing, the American Heart Association, and other local resources that might be available from your social work team or mental health team. With that, thank you for letting me speak to you today, and I'd be happy to take any questions.
Hi, thanks for your presentation, Dr. Lell. There's a few questions if you have time for that. One of them is, what are the early warning signs that cardiomyopathy is progressing toward transplant?
Sure, I think it can be variable depending on the type of cardiomyopathy a patient has, but really overall it's slowing down. Not being able to do some of the activities of daily living that patients are usually able to perform. And that's when we really start to think, will a transplant actually benefit patients and help them feel better?
Great, thank you. Another question is, how do you manage a child's activity restrictions when they have cardiomyopathy?
This is usually a joint conversation. The new term that we use is shared decision making over the last couple of years. Every patient is different, and even providers can be a little different with what they're comfortable with. I think we try to educate our families as much as possible, recognizing that some families are going to want to push the limits a little bit more because activity is so important to their child, while others want to be as safe as possible. And so there's not a one-size-fit-all answer for each patient.
Another question is, are there medications that can slow the progression and buy a little more time before a transplant's needed?
Absolutely. In dilated cardiomyopathy in particular, there are a number of medications, and we don't just go based on an ejection fraction or the fact that the squeeze isn't pumping well. Oftentimes, we can start patients on medications which may help them feel better and even sometimes improve the function of their heart. And even if their heart function is really poor, if they're doing most of the activities that they would like to do, growing well, are active, then we don't necessarily jump to transplant for those families.
Great, thank you. Another question is, how do families emotionally cope with the uncertainty that cardiomyopathy brings?
I think it's such a unique experience for every family. We know that some families have more support from their own families, their own communities, and other families have more hurdles that they may have to face. I think I think a good place to start is really talking to your provider about some of the resources that families can be connected to. Oftentimes families are just not aware of what resources exist and where they can get support. oftentimes we'll give them many different options, some of which are great, some of which just don't seem to work for that particular family.
Great, thank you. We have one more question. What does the transplant evaluation process look like for a cardiomyopathy patient?
It's pretty extensive. I call it transplant boot camp at my center. We usually have a full 2 days of education that we provide. We get additional testing that can include repeat catheterization, additional imaging. We oftentimes will send a slew of labs to really understand what the risks are for a particular patient. But I think the biggest piece is really meeting all the members of the team. For better or worse, I think our transplant team becomes a part of the family, and you get to meet the many members of the transplant team. It's not just a physician or one transplant coordinator. There's so many folks that become involved.
Great, thank you. There's another question in the Q&A box. An attendee says that they think their son's team concluded that his dilated cardiomyopathy was from viral myocarditis, but is it possible there is still some genetics involved?
It is. There have been recent studies that have shown that even with the diagnosis of myocarditis, when genetic testing is done, about 10 to 15% of those patients will have a positive mutation. And many providers think that in those cases, there may be what we call a two-hit hypothesis, where they had a predisposition to potentially having dysfunction of their heart, and then they had a virus that was the second hit for them. Some of this work has been done actually by the Pediatric Cardiomyopathy Registry and by Dr. Steve Lipschultz and his group.
Great, thank you. If there's any more questions, you can feel free to put them in.
I have one. This is Joseph. Yeah, Joseph Hillenberg, cardiomyopathy parent. My son's now transplanted, and so invoking moderator's privilege here. My question is, Dr. Lal, what would you say to families who are facing the potential of transplant? They're in heart failure right now, and they're maybe a little worried, or maybe perhaps even in denial about going to transplant, and maybe trying to push things off a little bit. I'm echoing my own feelings here. 14 years ago, and my son, when we found out my son might have to go to transplant, I was like, we're surely not one of those families. And we're all one of those families here. Everybody uses this in this session for the most part. So how would you maybe address the feelings of those families?
Sure. I mean, I think one of the techniques we've usually employed is actually trying to have those patients talk to other families, and not just talking to a family with a good outcome, but talking to families that have had some challenging people post-transplant. As much as we like to try to educate families, it's just very different than talking to another family that's been through this. And I'm not just saying this because this is a transplant families conference. I just think there's a lot of value in talking to folks who have been in your same position and who uniquely understand what you're going through.
Great, thank you, Dr. Lal. Since there's no more questions, I believe we can go ahead and close the session. Thank you for your time today.
Sure thing. I apologize that I'm at the airport, but if any questions come up, I think my contact information will be available.
Great. Thank you, Dr. Lal.